Good afternoon, ladies and gentlemen. Welcome to this meeting of the Perth and Kinross Integration Joint Board of Wednesday the 5th of June 2024. My name is Colin Stewart. I'm a councillor at Perth and Kinross Council and chair of the board. Can we first move to apologies and substitutions?
Thanks, Chair. We have apologies this afternoon from Chief Finance Officer Donna Mitchell and also from Susie Flower with Val Davis substituting.
Thank you. And I think that we have Mr. Grant online if there are any financial questions in the Chief Finance Officer's place. Can I start this meeting by just saying that we've received very sad news of the tragic and untimely death of Dr. Julia Hamilton, who was a senior partner at the Perth Whitefriars Green practice at the weekend. Dr. Hamilton was a very respected general practitioner who served the community of Perth for over 30 years, and this will have a huge impact on her patients, colleagues, and the wider community, as well as her family and friends. And we offer our condolences to everyone affected by this loss. But I also want to remark that just prior to the last board meeting back in March, we noted the very sudden death of Sandy Watts. At the time, the chief officer sent a message saying that all of the partners of the Perth and Kinross Integration Joint Board and associated groups were very sad to hear of the loss of Sandy Watts, who was our third sector representative and from Perth Citizens Advice Bureau. Sandy was a regular contributor and continually worked hard to ensure that the rights and entitlements of the most vulnerable people in Perth and Kinross were at the centre of decision making. She did so with decorum and humility, and her approach meant that she was both respected and heard, and it's very sad that we have lost her as a member of the board. Turning to happier matters, can we welcome some new members of the board? I'm very pleased to welcome Heather Dunk, who's a non-executive member of the NHS Tayside board and a member from there. And we also have Dr. Monica Doyle, who is taking up the place of Dr. Lee Robertson as a member of the board. I'd like to pass to the clerk to the board for a comment.
Thanks, Chair. Good afternoon, members. I just wanted to take the opportunity to remind all board members that the Integration Joint Board, like all public sector bodies, is now subject to stricter rules as part of the formal pre-election period for the UK general election on the 4th of July. This means that in terms of public meetings like today's and any other communications, it's important that board members, staff and the IGB as a whole are not being seen to portray the endorsement of any particular candidate or political party for the election. That being said, I don't expect this to be an issue in terms of the business that we have before us today, and I'm happy, Chair, to give any advice at any point. Thanks.
Okay, thank you, Clerk. Can I ask members if there are any declarations of interest in items on the agenda today? Mr. Black.
(6.3) I may have a declaration of interest that I'm a member of a organisation that deals with alcohol.
Okay, thank you. Are there any other declarations of interest? No. We'll then move on to item 3.1 on the agenda, the minute of the meeting of the Integration Joint Board of the 20th of March. For approval, can we agree the minute of the previous meeting? Agreed. Thank you very much. Next item on the agenda is the action point update. So we've got updates on actions 142, 147, 148 and 149. Are there any questions about the action point update? Can we agree that? Thank you very much. Next item on the agenda is any matters arising. Are there any matters arising from the minute or the action point update? No. Next item on the agenda then is the Chief Officer's strategic update. Mrs. Pepper, over to you, Chief Officer.
Thank you very much, Chair. I'd just like to update the Integration Joint Board by looking back over a series of events which have been quite significant just over the last 2 months or really 6 weeks. And many of these events have been attended by IGB members, so we've really appreciated that. The first event that I would like to just commend was the Mental Health Conference that took place on the 2nd of May, and pay tribute to Chris Lamont, who I believe is online as the lead for our community mental health and wellbeing strategy, and provides updates to the IGB on that, and other teams across the partnership and many third sector partners for the organisation of this successful event. There were over 250 participants with keynote speakers, including Dr. Jane Bray on public health data and messages from that and next steps. The Linda Hunter from the National Suicide Prevention Strategy, and Wendy Halliday from CME Scotland with a focus on reducing stigma. And it was a very successful event, and I know that there were some IGB members at that. Secondly, the Learning Disabilities Week, which was a week-long range of activities starting the 6th of May. And significantly, the launch of Hear Our Roar, which is the Perth and Kinross local involvement network for people with learning disabilities. And the first meeting of that network, supported by the Centre for Inclusive Living, will take place, I think it's today. And that's a great new forum linked into the national network for people with learning disabilities, and really quite a superb opportunity for us to have people with learning disabilities influencing change across public services and civic life in Perth and Kinross. And then on the 23rd of May, we had a What Matters to You celebration event that took place at PRI, and it was a culmination of a year-long engagement with staff on the What Matters to You initiative, and I've put some copies of the report of that year-long activity with case studies, Perth and Kinross case studies, and some of the key messages from staff around that a compassionate workforce or a compassionate workplace looks like and needs to be. And significantly, there was a keynote presentation by Sean Mayer, who is the Scottish Government Advisor for Person-Centred Care and Improvement, and he noted in his speech that this work, the What Matters to You work, and the rollout of care opinion in Perth and Kinross, which has been whole organisation wide for the Health and Social Care Partnership and beyond with our commissioned services, is actually quite marked and unique in Scotland, and something that he has not seen replicated. So I think that was really important to draw that to your attention. And looking ahead, we have Carers Week beginning the 10th of June, and a programme of activities, a WhatsApp guide available to you. And we'll make sure that if you haven't already received that you have an awareness of that. And really just to finally update the IGB on the recruitment process to ensure that to put into place a new senior leadership structure with an integrated approach to that. And the 2 new roles of integrated health and care, one for older people and one for adults, is currently out to advert, with the appointments process concluding at the end of June. So just to keep you posted on that. Happy to take any questions, Chair.
Thank you, Chief Officer. Are there any questions On the Chief Officer's update, Mrs Hamilton.
I don't know if this is the right point. It's just when you were, I was going to look at any other business, but just when you mentioned Carers Week, it was just to, for noting that this is Volunteers Week as well. And I just thought it'd be worth making sure that we thank all the volunteers. I know that I've been doing some work and I'm going to Friday to Perth Royal to give out volunteer awards. So it's just to have it noted in the minutes that we appreciate all the volunteers across the whole system. Thank you.
Oh,
That's it. Thanks very much, Chair. And I'm actually very pleased that Dr Lefevre and Dawn Fraser are able to be with us today, and really to bring the IJB right up to date in relation to where we are with the programme and the model of care. Recognise that the report in front of you is a very lengthy report, but it does go over material that's already been before you and reported to the Integration Joint Board, and acknowledging that there has been frequent updates to this IJB as well as Dundee Angus and NHS Tayside Board on a monthly or bi-monthly basis, but we felt it was important to bring this work in, or the culmination of the work into one place so you can see that in one report, and tell a coherent journey. I also have apologies from Sandra MacLeod as Deputy Chief Executive of NHS Tayside, who is the Joint Executive Lead now for the programme, and Sandra's unexpectedly off today, otherwise she would have been here too. In terms of a very quick summary, there are 4 highlights in the report from page 14 onwards, and those are the model of care development, and you'll see that there's an early draft of a single model of care which has been shared with the programme board, and a new model of care steering group which has now been established and working away quite vigorously. Started in April, and I know that you've already had, I think, a meeting and 2 workshops already. And Dr Lefevre will outline the framework that underpins that, and just to highlight the co-production and stakeholder engagement, an approach to co-production and the stakeholder engagement that will, as part of the workshop activity, but will also shape the final model by the autumn in 24. Also in the report, as had been indicated previously, is the beginnings of a financial framework which can build or work towards a commissioning model for the IJBs. So it's a very, I suppose, quite rudimentary, but it's probably the first time that we've managed to provide a whole system financial envelope for mental health services across the whole of Tayside. So there's some information in the report on that, and a little update on the learning disability services redesign work which took place in the V&A, or in partnership with the V&A Dundee in April, which is beginning to reinvigorate that work which had stalled for a period, and some updates on the engagement and co-production approach through the Care and Share Together initiative, and also updates on the early intervention in psychosis as emerging good practice, and an outline of some of the local community mental health and wellbeing strategies, both in Perth and Kinross and in Angus for you. So in summary, the programme is advancing towards a whole system model of care, emphasising community-based activities and a shift in the balance of care towards community with substantial stakeholder involvement. I'm just going to hand over to Dr. Lefebvre, if that's okay, Chair, to take us through a short presentation.
Thank you very much for the invite, Chair, to present an update on the, I say, developing model of care. This is very much an update because it is a very sort of dynamic process. As the paper says, the steering group for the model of care met fairly recently in April to establish terms of reference, and we've just had 2 half-day workshops over the past 3 weeks. So this is really a hot off the press update on where we are after the 2 workshops, and also the work ahead to finalise a model of care over the next 6 months. On the next slide, please. So we fairly early on decided that actually the work stream of specialist mental health couldn't be taken in isolation, that we needed to think for the whole pathway to work of communities and primary care. And the model that seems to integrate best is what we're terming the place-based integrated model. And these models have been established and progressed quite successfully, particularly down south, but also locally. In Angus, there's been some very good with the hub model in North Angus that's had some very positive results. So we're bringing that together as a place-based model. And what do we mean by community places? Essentially, population groups are probably up to 30 to 50,000. That's very rough, but they're established and defined according to what makes best as the community. So, for example, in P&K, it might be a population the size of the city of Perth or North Perthshire. And the idea being that that is the community and all the community assets getting together in an integrated way, including primary care, specialist mental health services, voluntary sector services, social care, housing, to be able to get together in an integrated fashion to plan and deliver the community mental health services for that area, all encompassing for persons with the less and more complex mental health needs as well. And that's with the service delivery actually built in the community and operating from what would be the most appropriate community hubs, whether that's GP practices or any alternative voluntary sector services, or whatever's best for that local community. The model may require separate sub-teams to work, but really we're looking the model to be very much needs-based, that is co-produced and managed and just locally based. So trying to avoid the need for repeated assessments, repeated referrals to different teams, that an assessment of need is made and that and those needs are met in the most appropriate place possible. The actual way that service is delivered will very likely differ depending on what's available and how each of the communities are able to, as I say, are able to provide. So there will be differences within the communities, but the core, I suppose the essential must-dos interventions should be very similar. Can we go to the next slide? So what are the sort of core principles that have been agreed? that multiple points of access to a community mental health service should be enabled, including self-referral. So there isn't the need to pass by GPs to access mental health care. Although many people will access mental health care through their general practitioners. A minimal number of assessments, which would mean agreements on what shared assessments and standards across voluntary sector, primary care and secondary care are accepted. Common pathways across the system for specific needs and problems and diagnoses, for example, depression or ADHD. And agreed protocols which will need to be managed according to that, and that will need to be discussed and agreed between all stakeholders, particularly primary care, secondary care, the interfaces, prescribing. That when we consider all care, it has to be patient-centred. What matters to me being at the key, and that we use patient recorded outcome measures to record that, to measure that and improvements. So we keep patient-centered care right at the core. The interventions would need to step up and down of care, facilitated depending on patient need, without the need for cross referrals or waits, to which we currently experience to see a certain professional. So we're trying to minimise any waits and requirement. Grab the next slide, please. This is quite difficult to read. I've tried to make this as simple as possible. But essentially the big blue circle would be the core integrated community mental health service for each locality, and there may be, as you say, 3 or 4, probably 3, I imagine, for Perth and Kinross, of those blue circles, which will be that integrated service involving all the primary care, secondary care, community mental health teams, as well as the voluntary sector services, as mentioned. And that entry to that mental health service, I've just put one single arrow at the bottom of going up and down, but that is supposed to, rather than be overcomplicated, it's signifying multiple points of access into the service. And that within that blue area, the big blue area, would be the single shared assessment and relatively, as say, straightforward assessments and interventions and treatments, including the whole array of social care, and that from those assessments, care can be stepped up to deliver particular interventions that are needed. For example, for people with more complex, severe mental illness, recovery and rehabilitation services, the early intervention in psychosis, intensive home treatment, and all those sort of needs-based functions will be needed to be developed within each of the localities, and they may be delivered in different ways. For example, Dundee currently has a separate early intervention service, but that might be in a different locality delivered within a different group of people. Coming out of the blue circle are the Tayside-wide services. And, for example, inpatient care or specialist services, which simply because of the small numbers involved and the need for team working, need to be sort of delivered on a Tayside-wide basis. Examples of that, like for example, the Tayside eating disorder service and inpatient care as well. And those 2 arrows coming out are the things that we particularly need to focus on, those smooth transitions between the specialist services and the core community delivered services. The big arrow on the right with different shading is really that the most important thing of care being stepped up and stepped down in a smooth, facilitated way, without the need for cross referrals or excessive paperwork or long waits. And the downward is particularly important because at the present services, there's a marked upward trend to specialist care. So we've noticed, or certainly community mental health teams have got huge numbers of patients, and it's been very difficult to step down the care of patients within community services purely because the wider community delivered care just isn't there at the moment. So if we rebalance that care, we'll be able to step down the care to be able to focus more keenly on the high intensity interventions. Could you add the next slide, please? I'll very quickly skip over this slide, as this is a sort of a slide that we borrowed actually from a service in England, but it basically it does focus on what we're doing with putting the patient right in the middle of the care, with family and immediate social supports around the patient, primary care, and then the wider community supports. And I apologise, you probably won't be able to read that, but social care services, housing, activities, all those community assets that are around and utilised. And the rather colourful sector at the top left being the bit that's sort of specialist mental health services. If we just move on to the next slide, I've nearly finished. So what would be the core functions? Assessment of the community mental health service, assessment and advice on brief treatments, the specific psychological, pharmacological and social interventions required on a needs-based basis, support to access all the community assets, and that may entail new staff in way being signposters to ensure that all the community assets come together to be able to be really focused on patient need. That the stepping up of care is seamless and is based on need, and that we also, one of the big issues is the gap really in services for developmental disorders, assessment and support, and the model really needs to provide an answer to how we manage the very large numbers in the community coming forward for assessment and support for that range of disorders. I'll just go on to the next slide. I think that's just about. So what are the next steps for the work stream? Firstly is socialising and developing the model further, and this is the first time we've had the opportunity to talk about the model in a more public environment. We need to discuss more about pathways and operational considerations regarding how the model will actually work. And that will involve a lot of discussions, as I say, with all the stakeholders. There will be wider Tayside discussions, but fairly quickly it will come down to locality discussions, because ultimately within the communities it's a co-produced model. So the people that matter in the community will need to get together. For example, the city, all the stakeholders in the city of Perth getting together to decide on how the model is going to be delivered, and to manage and support and hopefully even commission the relevant services as we go forward. We will need common standards of assessment and risk assessment and care planning across Tayside, and outcomes, for example, particularly patient recorded outcomes, experience measured, but also condition specific outcomes, for example, to show and demonstrate how the service is benefiting service users. And I finally put we absolutely need to further develop IT and digital innovations to support the model going forward, which will need to be on a Tayside integrated basis. I'm be very happy to provide updates in due course as things develop.
Thank you very much, Dr. Lefevre. Have we got any questions or comments? We'll go to Councillor McCall first, then Serene, and then Dr. Peters.
Thank you. I think I just want to say, first of all, thank you for everybody who's involved in bringing this report here. It's been very good to see the whole chronology of events and activity. It's huge, actually. So don't apologise for it being a long report. I think it just shows the amount of effort that's gone into it. So that's just a general comment. And I think it's very encouraging to see the progress that's been made. I do have one question. It was, I think, your third last slide with the onion type thing. And I've seen that friends and family were in the outside sector. I'm not 100% sure why they're so far out, because depending on, for example, people with learning disabilities that have, or learning conditions, very often friends and family can either be the cause of it, but very often they're the support network, and very often they're forgotten about in terms of dealing with the individual. So I just think that some of that needs to have a little bit of crossover. Just both in mental health and learning disabilities, two quite distinct strands. I think they're not necessarily the same causes and solutions for everything. So thank you.
Yes, a brief, but I completely agree that actually that was a borrowed slide. It will be developed further, putting that, and I absolutely agree. It's in my commentary on it, I did say around the patient, which is family and friends and the immediate social context, but that does need to be altered in a final diagram for ourselves.
Yeah, but I also am aware that sometimes the family context or the environment in which someone lives and interacts most can also be sometimes the cause. So we just need to think about having that perhaps be more flexible. That's all. Thank you.
Thank you very much. It's not a question. It's really just to set out that I think there are real opportunities with this, because as Dr. Lefebvre sets out, that there's an ideal size of community, and we actually have 3 localities that are actually split up into roughly 50,000 people, Perth City, North and South. How that might look in the different localities would be, could be very different, but there's something about having that, centralised place, and it may be more than one place, but certainly a location where you can identify that support. And just to say to the IJB that I've been involved with the refresh of the community planning partnerships local outcome improvement plan, and that's likely to have 3 elements to it, and the 3 elements are about tackling poverty, which is a root cause of mental distress or concern for people's well-being, employability, which is about education, learning and moving into employment, and the third aspect is about mental health and well-being, whatever that might look like. It might just be well-being. So I think that fits very well with the model that we're presenting here, and I know Chris is online, but it fits very well with our community mental health and well-being strategy and our redesign of primary mental health services. So Chris might want to say something about that, but it's about beginning to see how this will align in terms of that whole strategic intent.
Can I come in, Jackie? Sorry, there's not a way of putting my hand up on the thing. So absolutely, and just to offer some assurance to IJB board members, we're through the middle of all of this with Pete and the team from an NHS Tayside and Tayside-wide perspective. And as Jackie has said, we're looking at redesigning and redeveloping our mental health strategy over the next 3 years, starting from next year. And we're also currently working on primary care mental health. And between those 2 elements, they should dovetail together, which fits very neatly and nicely with what Pete's promoting forward as this model of care. Because again, going back to what you suggested at the beginning, it's around being place-based, which wraps around the individuals, involves communities, involves all the organisations, and it's actually really quite an exciting time to be taking this forward.
Thank you. Serene.
Thank you, Dr. Can I just a wee personal thing? Listening to you, I thought there was a sense of, from yourself, an ambition to do well by people. And it's a question relating to that, if you don't mind. Perth and Kinross is one of the few huge rural areas who are required to provide a suite of services. The model as it stands, very good, and would work in an urban environment. And it does in England in the main. It's an urban environment. Great Manchester, the example of that. But here, outside of Perth, the areas that have got a lack of a workforce, not consistent ways of coordinating the resources that's already there. Some are quite good and some are not so good. So I was wondering if you, a future meeting, be looking at what additional challenges we've got in relation to rural areas. For example, is there a way of dealing with a rural area by interim measures and identifying what's there? And some of that will change. You might get lucky and get some staff will come in and work in those areas. But it seems to me, if we're not careful after all the work and empathy, that we could end up with some people requiring a service that's not available to them. And that would undermine the whole concept of what we're doing. So I ask you that. And the second thing, what relationship has this got with CAMS in terms of the significant number of children and families involved? Are you going to have any relationship with that as part of this? Or is it going to be, as it seems to be now, this is just my view, it may be totally wrong, that they're completely separate in terms of organisation, access to, and issues around where GPs constantly trying to get appointments for families and unable to do so. So I was wondering, is it going to be a hands-on with yourself on CAMS, or is it going to stay there without any friends?
Thank you very much. That's a very complicated range of questions there. I'm very hesitant about giving answers to the urban-rural situation, because actually a lot of the answers would need to or should come from the established group of that locality to co-produce and to identify where the gaps are, and to commission and develop what services, particularly sort of social supports, need to be provided to the more rural areas, and that needs to be co-produced by service users, as well as what voluntary sector and health and social care partnership and health. So that needs to be done on a locality. But so it'd be amiss of me to give answers to that, but I think centrally we need to try and support that as much as possible from NHS Tayside mental health services, but ultimately a lot of the decisions and empowerment should be within that locality mental health service. You mentioned CAMS, and that's very, very interesting, because one of the considerations, although we're starting from a general adult perspective, which is working age adults, which is I suppose my remit, and I haven't got a managerial remit for CAMS or old age psychiatry, or psychiatry of older peoples, but particularly the place-based model really fits with more ageless services and needs-based services. So I would hope and envisage that there is a vision that actually this could be extended downwards the age group and upwards the age group, depending on patient needs. But that would need to be, as I say, more widely considered within those other CAMS services and psychiatry of older people services. But if we can get this right for the vast majority of people as the core service, then other things a lot of other things become possible.
You and I are the same. Sorry, I've got cramp, but there's a doctor in the house. The bottom line of it I was asking is this. Don't disagree with a word you've said there, but are you going to be able to flag up these issues during your work so it isn't left or it's going on somebody else's table and you're not involved in it?
Yeah, thanks very much, Ian, because I think just to emphasise the collaboration that's taking place, and when we talk whole system, we're really meaning that the relevant people from Perth and Kinross are involved in the development of this as it's taking place and as Dr. Lefebvre set out, this is not the finished article. This is where we are just now. So I know Chris is online, but we have others who are involved in a number of these work streams from Perth and Kinross who understand the rurality, who understand the community challenges that we face, as well as others from Dundee and Angus as well. So this is about trying to ensure that we have a whole Tayside approach for those who require those very specialist services, but there will be I need to ensure that we have consistent processes and consistent treatment options for people, but how that might play out in that very rural local context might look a bit different, but the access to the service and the service that is provided should be consistent. So there is a challenge in that, but I can assure you that that's certainly the discussions that we're having.
Thank you. Dr. Peterson and then Mrs. Auld.
Just a couple of quick questions. First of all, I'm just interested to know how this integrates with things like the wellbeing nurses that are already and social prescribers that are already involved with primary care. And then my second query, which I think is probably more operational, I really appreciate everything that's been done about taking the services out into the community. However, one of the biggest things and one of the biggest challenges that we always see is accommodation. So at the moment, we often see that services are moved into or suggested to move into environments that maybe aren't the best place to have them, that have issues about car parking, being able to access the public transport, that actually fundamentally then affects the ability for patients to get the care that they need. How, when we develop these models, do we ensure that although we can produce an aspirational, fabulous model, that actually we have the infrastructure to be able to move it forward, rather than having, as we have with some services, they move from pillar to post because there's never the accommodation to make sure that we can make those substantial and permanent changes.
Answer the first question about it's the practice nurses, mental health nurses, and we would be looking at, obviously this needs developing, but an integrated mental health will involve the primary care and will involve the wellbeing nurses as part of this wider service that's integrated, that respects each other with a smooth transition. So we're avoiding the silos, but it will entail people working very differently. And that's the hearts and minds bit, that actually the vision is very different from currently, where people are embedded in their teams and have their referral criteria and bounce patients or refuse referrals, leaving service users unsure of what's going on. So it will entail people really respecting each other, working together on a needs basis, which will be a challenge moving forward, and a hearts and minds thing, and working differently. The second point I've just accommodation. Yeah, I couldn't agree more. Mental health tends to be a last resort, and wherever I've worked through my long career as a psychiatrist, it's always tended to be using second-hand accommodation where, there's never been fit for purposes, whether it's mental health being put into, as in the city of Perth, in a old maternity unit at the PRI, to old GP premises with mental health tends to be put in old community resources. I think we've got to be imaginative over where best to place things, because we haven't got new money to build new things. But there are a lot of good community resources, and each of the proposed communities may best decide, actually we've got a really good facility that the voluntary sector uses, or something that connects people best to the community. Let's have a core base, but chances are it'll be a loose network of services, that it won't be that having one central base for a whole community mental health service is unlikely to be practicable. It's more a network working together to the best of patients, and that may be delivered through a number of different sites.
I'm just going to highlight a couple of examples. I know when we had the presentation from the NUC, we had quite a discussion about the importance of the environment and that being welcoming and feeling like you're going into someone's home almost, and the feeling and the calmness that came from that. We heard that firsthand, but also that there are opportunities that will become available to us, because I know that we've had discussions with the Letham for All and the new hub in Letham, where they have actually set aside space to encourage staff to come in and work from that location, but also for want of a better word, a treatment room, but certainly a location where people can come in, have coffee, have something to eat, and actually make an appointment to see someone, or see someone just on an ad hoc basis. So that's something that we're looking at in terms of how do we integrate into that absolutely brand new building with a much wider wellbeing focus and integrate it into that. So I think that when opportunities like that become available, we need to grasp them.
Thank you, Chief Officer. And obviously, just to the first two of the 12 priorities in the change programme are about specifically about physical environment as well. Did you have another question, or was that both of Dr. Peter? No. Online now, Ms. Sold.
Thank you very much, and thank you for the report and the excellent presentation. You mentioned within it the importance of integration and information, and also digital aspects of that. There's an expectation of patients that when they have a consultation or attend for an appointment, that the relevant information will be available to the whatever healthcare professional that they're meeting with. And so I just, unfortunately, that's not always the case, and it's often not the case. And I just wondered what plans were in place to move that situation on, particularly when the centre of what you're talking about is place-based. So information will need to be moved. And I wondered if, for example, consideration had been given to patients holding their own notes. Thank you.
Thank you very much. Yes, that is a challenge, because we have our electronic systems which are different across areas, and that needs to be a key consideration in the model of access. And it may be that certain systems that are only accessible to NHS, that we need to have common routes into those, and that may need consideration of honorary contracts and things to enable people who maybe don't work for the NHS directly to have access on a needs-based process to enable that sharing of information. There's very much interest in digital passports for certain conditions, for example, that are able to cross services, and although they will need a lot of development going forward. And couldn't agree more that actually patient held records and care plans are really important, and if we can get better at doing that, and implement some of those, that would be a real good step forward in the model. It is a challenge because, you know, as you'll know, there's the security of patient records and IT systems is a cause for concern in the NHS, and that's obviously been in the news recently. But I'm sure there are ways around that can be of benefit for the system.
Yeah. Thank you.
Thank you, Mrs. Hamilton.
Thank you. Thanks for your presentation and the report. It's good to see it. I suppose my question, I'm a bit more happy after hearing Chris's intervention about the work that's being done in our Perth and Kinross strategy and the work that he's talking about. A lot of work is hand in glove with yourself. So that's great, because I think, you know, when we're looking at the whole picture, one of our problems has been traditionally we've always picked at bits, did a bit of a review, then picked at another bit and did another bit of a review. And this whole system working is probably key to it all. What I was really interested in, and maybe this is a bit operational, but you talked about self-referral in the system, and then you're talking about stepping up and stepping down. What parts of the system do you expect people to be able to self-refer? I'm assuming you can't self-refer directly into a community mental health team. Is it more at the moment it's in through the third sector, or is that when you're stepping up or stepping down? Sorry.
There are some really good examples of this in operation in England. For example, self-referral to online. We got 2 psychological therapies to an initial mental health assessment, and that mental health assessment maybe to the voluntary sector, to a mental health worker, primary, you know, a person working to a standard assessment, and then being signposted to whether it's, depending on the assessment, to it may be a social care intervention, or it may be a mental health intervention, or care stepped up at that point to, for example, an early intervention in psychosis, if there were concerns. Yes, there are obviously workforce issues in the way of training and what standards are we going to use for assessment and outcome measures, and how do we measure what the patient needs at that point. But there are really good examples that we can develop and operationalize without having to reinvent things. So I think it is important to have a route for self-referral, because otherwise GPs become the funnel and the pressure on primary care is immense. But likewise, that self-referral needs to be managed in a step basis. You know, we can't have it. The system would collapse if everybody could self-refer to a CMHT, for example. But the CMHT will change, because at the moment, yeah, that's what I would see as quite a siloed service, and we need to look at functions more. So a patient being assessed, and then depending on their needs, they may need to go to a more specialized service depending on that need, or generics. For example, if a person with a severe mental illness with complex needs would need quite multidisciplinary care planning, and that may need to be within a separate team providing that multidisciplinary care planning consultant-led service, whereas somebody just needing a single intervention, maybe with a single practitioner for 6 sessions, wouldn't need to be within that service. So it's more, what are the components of a needs-led service, and how can that best delivered within that place-based service? It's a complicated answer, but it's
yeah, it was just the whole capacity of this to be looking at a whole system. It really was quite stark for me when I went to the mental health event at the Perth Concert Hall, and you walked into that arena, well, the area at the front, and the amount of third sector engagement in Perth and Kinross was just phenomenal that I just didn't appreciate. And I thought, when we can harness all that with the kind of work that you're doing as well, there should be no stopping us. So thank you.
Thank you. And am I right in thinking as well that, so I don't know how widely it applies in GP practices or primary care settings, but there are some settings that will offer, you know, when you phone up, instead of making an appointment with a GP, you will make an appointment with a mental health nurse. You know, there are appointments available at some of the practices, but I don't know how widely spread it is.
So this is part of the primary care improvement plan, where there is mental, these are all wellbeing nurses. So most practices, although not all, we're trying to develop it further. We've got a fabulous person at the moment looking at it. Yeah, so patients can ring up and self-refer straight into the wellbeing clinics. The difficulty we often find, though, is crisis management, because they aren't there all the time, and also there is a limitation around prescribing and that sort of thing. So they're a phenomenal resource, but there are limitations to what they're able to do, so it often can come back to the GPs to follow things up.
Thanks, Dr. Peterson. Have we got any more questions or comments, or any from online? Councillor McCall.
Thank you. I just want to make one quick comment about the community engagement and work to that extent. And Jackie mentioned Leitham for All. A large part of what's in that establishment was driven very much by input at the very beginning, about 10 years ago or more, before I became involved with them at all, from the community themselves, but what is it they needed and that they wanted. And so I think the only thing I would really say is that whenever we do talk about how we design our services, particularly when it comes into the on-the-ground implementation, really we need to be led by the people themselves. I mean, to find a way of making that as comprehensive as possible. And certainly as a trustee of Leitham for All, I can say that we have seen that the benefit of that, because the uptake of the services and the utilisation of the facility by the local people is far beyond our expectations, to be honest. And hopefully we can use that as some sort of test of change that we can take out to some of the more rural communities as well, and see how we can model that elsewhere. So I think listening to the people in the first place about what they want, what they need in their localities, will be crucial to the success of this. Thank you, Chair.
Thank you. Have we got any more? Nope. Okay. Thank you very much for the presentation. If we turn to the recommendations in the paper, we can note the contents of the report. Do we authorise the Chief Officer to work together with the relevant NHS Tayside staff and other chief officers to ensure there's whole system leadership and continued delivery of the programme at pace? Yes. Do we authorise the Chief Officer to work with the NHS Tayside Director of Finance, the 3 Chief Finance Officers, the interim and the relevant NHS staff, and the other Chief Officers to deliver a financial framework to support delivery of the model of care and shift the balance of care from inpatient to community? And can we note the intention of the IJBs to develop and approve a commissioning framework for mental health services by next March to enable them to commission an appropriate level of inpatient services in the following financial year? Agreed? Okay, thank you very much. Okay. Thank you. We'll now turn to the next item on the agenda, which is the Alcohol and Drug Partnership Strategic Delivery Plan and the Annual Reporting Survey. Here to introduce the paper, we have Kenny Ogilvie, who is the Chair of the Alcohol and Drugs Partnership, and Charlie Cramner, who's the Coordinator for the Alcohol Drugs Partnership. Mr. Ogilvie.
Thank you, Chair. I'm just going to pass straight over to Charlie.
Good, thank you, Kenny. The purpose of this report is to present the new Alcohol and Drug Partnership Strategic Delivery Plan 24 to 27. To to the IGB for approval for services delegated to the Health and Social Care Partnership. The report also presents the completed ADP Annual Reporting Survey 23-24 for approval for services delegated to the Health and Social Care Partnership. I'll talk first of all briefly about the Strategic Delivery Plan. The Scottish Government requires all ADPs to develop a local alcohol and drugs strategic plan to align local and national priorities, planning and investment. The previous Perth and Kinross ADP Strategic Delivery Plan ran from 2020 to 23. The plan had 4 key priorities and 6 cross-cutting priorities. I'm delighted to say the ADP made significant progress during this time in achieving these priorities, with some key achievements including the establishment of a multi-agency near-fatal overdose pathway, an increase in the number of take-home naloxone kits, the establishment of a living experience group, the formation of IDART, the Integrated Drug and Alcohol Recovery Team, the establishment of a revised process to facilitate access to residential rehabilitation, the implementation of a whole family approach across various projects, and the collaboration with the Community Justice Partnership to develop a new voluntary through care model for people returning to their communities from prison. This work led to several key performance improvements, and these included a reduction in drug deaths from 34 in 2020 to 21 in 2022, a reduction in near-fatal overdose incidents from 201 in 2020 to 93 in 2023, an increase in the number of approved residential rehabilitation places from 0 in 2020 to 17 in 2023, an improvement in treatment waiting times from 89.4% of people who begin treatment within less than 3 weeks in 2020 to 94.4% in 2023. And finally, an increased number of prisoners registered with the GP on release, with all short-term prisoners scheduled to be released from both HMP Perth and HMP Glenorchy, who were part of the new voluntary through care scheme from December 23, registered with the GP on release. Following completion of the previous plan, a new 3-year strategic delivery plan has been created. And this plan utilises the Scottish Government's National Mission on Drugs Plan 2022-26 priorities and extends this focus to include alcohol, to reflect local needs. In order to develop the new plan, an extensive consultation exercise was undertaken with all ADP partners from the statutory sector, the third sector and recovery community. The new plan focuses on 4 key local priorities, and these are prevention and early intervention, reducing the harms caused by alcohol and drugs, developing a recovery-oriented system of care, or ROSC, and also getting it right for children, young people, families and communities. Responsibility for implementing the actions outlined in the plan will be devolved to the various ADP subgroups, who in turn will report progress to the ADP strategy group, which meets on a quarterly basis. And secondly, I'd like to just briefly mention the ADP Annual Reporting Survey, which is the second part of the report. The Scottish Government requires all ADPs to report on a range of aspects relating to delivery of the National Mission on Drugs each year. Since 2023, this information has been collected via an annual reporting survey. Responses to the survey highlight the progress that has been made locally during the last 12 months in achieving the aims of the National Mission on Drugs. And these include the implementation of the Medication-Assisted Treatment Standards, the MAT standards, which aim to provide accessible, consistent and high-quality drug treatment services. An expansion of our recovery work, which has seen the establishment of our new living experience group and an expansion of our recovery-focused groups and activities. And also further work with Justice colleagues to provide support for people returning to their communities after leaving prison. So in conclusion, the development of the new 3-year ADP Strategic Delivery Plan marks the next phase in the work of the partnership to reduce the harms associated with alcohol and drugs and facilitate recovery opportunities for people in Perth and Kinross. Thank you, and both Kenny and I would be happy to take questions.
Thank you very much. Have we got any questions or comments in the chamber? Mr. Black.
Thank you very much for the report, Kenny. And it's good. I had the privilege along with Beth Hamilton of visiting the project and see the work that you're undertaking, and it's encouraging. It's encouraging for a cynic like me. It's encouraging to see absolutely that holistic approach being undertaken. So more power at your elbow, but the relevant data that you've got in your priorities shows why it needs to be working. That everything is higher, the deaths are higher, although they're coming down. The lived experience, I have a great belief that lived experience is really important in that. But also, I start to get concerned that lived experience is lived experience maybe 3 or 4 months. Again, that people have that lived experience. I'm not saying because I don't know, but because we create to an extent, we create a poverty industry 30, 40 years ago, and my fear is sometimes we're creating an addiction services and addiction industry as well. I'm not saying that there are, but it's important. It's important that the work that you are undertaking and the reporting things that you're showing is maintained to the full. Maintained to the full, because the increase, as you say, 5%, five times more people dying from 2010, 2013. Yeah, it's frightening. It's quite frightening. I hope, and as I say, it was really encouraging to go and see the holistic approaches you are taking, but it's a big task. And I think one of the drawbacks to me, and it's only for me, and I know the match standards are national, that we've got brief interventions that tell us nothing. And they tell us nothing. They do tell us the outcome of the brief intervention. What is the impact in society? What is the impact on services? It only tells you we've got a brief intervention. I think that the alcohol and drug partnerships really need to be looking at leadership standard, because I've seen for the last 9 years everybody gets above 90% when they're reporting ABIs, like, but they've never told me what happened. How many people are the ABIs he's seen the same person maybe 3, 4, 5, 6 times? Okay? There's no evidence. It just says we've seen somebody. So hopefully that could be expanded on. And just quickly, I was kind of concerned when I read page 93 of 136 of the underspends that have been protected and transferred. How do we, can we've got that level of impact on society? What are we underspending? And I would be looking for it to be overspent, and challenging that. That's me. Thank you very much. As again, I say I was quite pleasantly encouraged to go and see the works that you have made.
So thank you for that, and I'll probably work through them in reverse order. In terms of the underspend, a lot of the underspend has built up. We've had a range of funding from different tranches over the past 2-3 years, and quite often that funding comes in sort of close to the end of the financial year, and then obviously we try to use that funding, so obviously it's going to have the biggest impact that it can, and try and invest it strategically. And invariably, most of that funding goes on posts, and again, recruitment processes, etc., take a while, and that's after the chance to work out the best area to spend it in. So again, we had a fair bit of funding coming in separate tranches. I think it's unlikely that will, the funding will continue, but we're unlikely to get new tranches as well. So that underspend will decrease over time. It's not as if there's a massive demand out there and, we've got plans in place, we're just not spending the money on it. It's not that at all. It's just a way of, it's just a reflection of the way that the money's coming in, and it's taking us time to recruit to those posts. But we're pretty much up to speed in terms of the recruitment and in terms of our strategic delivery plans. So that underspend should decrease with time. Plus, we have got one-off plans in place as well to maximise use of that funding. In terms of the performance indicators and measuring impact, there are a range of performance indicators linked to the strategic delivery plan. That performance framework is still a work in progress, and we're working very closely with our colleagues in public health to fine tune that one as well. So we've got a really strong performance framework to determine any impact. And in terms of the challenges facing the ADP and substance use services, I mean, you're right. What we have to do is try and monitor drug trends. For a while in Perth and Kinross and nationally, drug trends have been changing. They're moving away from opiates with an increase in stimulants, crack cocaine. Benzodiazepines are a major issue as well. And alcohol is an enduring issue. So it's about making sure we're spending that money where it's required in Perth and Kinross. And that's a challenge for us. And the other challenge is just keeping an eye on those changing drug trends as well. I mean, people have seen in the press, there are synthetic opioids, really super strength, that are being found nationally now. So it's trying to be ahead of the game and make sure we've got actions in place to mitigate any impact of these new drugs as and when they hit Perth and Kinross.
Councillor McCall.
Thank you, Chair. First of all, thank you. The report's great. Thank you. My question is really around prisoner healthcare, because it refers to, I think, to people in prisons as opposed to necessarily people. I'm wondering if that includes people in remand and whether or not it includes people in community payback orders. And also, just maybe for completeness, it's the Community Justice and Safety Partnership here in Perth and Kinross, rather than just the community justice. And I think that's meant, and certainly we get reporting into that committee on the community payback orders in those areas. And I'm just curious to know where that fits in, because I know from visits to the prison, in fact, a recent visit to Stirling Prison as well, that substance abuse is a significant issue, both in perhaps a contributing factor to people entering the criminal justice system, but also getting out of it and staying out of it. And that's a wider then impact on the whole community in terms of the mental health strategy as well, etc. So perhaps if we can maybe get a wee bit update on how that all integrates together. Thank you.
Thank you. As we've completed, and I say completed, MAT standards in the community, in terms of we've now reached the Scottish Government deadline for implementation, which we've submitted information there. Work continues with MAT standards in the community. We haven't finished. However, we now move on to MAT justice. So there's now a whole programme of work around implementing MAT standards across the justice sector. And that isn't just in prisons, that includes the whole different aspects of the justice sector, from police custody through to prisons, through to people who have community orders, and also people on remand as well, who are included. So as we did with the MAT standards in the community, we'll work with the Public Health Scotland MIST team, the MAT standards implementation team, and they will help and support us implement these standards. So we have different timescales, different work that we have to do. That work will really begin from July onwards, once the publication of the new MAT standards community benchmarking report is published. That benchmarking report will include some information around justice, because there has been some work being undertaken to date. But from July onwards, the focus will very much turn to justice and a continuation of the work that's been going on there. We are working very closely with the Community Justice and Safety Partnership. We'll amend that, thank you. But we are working very closely with them, and we've already had examples where we've worked, as I pointed out in the report, with voluntary through care, and we've been heavily involved in the design of a new process around voluntary through care for Perth and Kinross, which does seem to be producing some very positive results, but it's very much a work in progress. The key focus for us, as it has been through MAT standards in the community, is to make sure that what we're doing is what's best locally for the people of Perth and Kinross. Lots of the MAT standards work in other areas. There's lots of fantastic bits of information, bits and projects that are being carried out. What we'll want to do is to take that on and look at it from a local perspective, because obviously we have our own unique challenges with 2 prisons in the area, and also, as was discussed in the previous paper, the challenges of rurality as well. So we'll take all that on board and try and ensure that we produce positive local solutions.
Thank you, Mrs Dunk.
Thanks very much for the report. I found it really useful, and following on from the mental health conference and discussing the MAT standards, it all fitted into place for me, so thank you for that. I'm really interested in your priority 1 and priority 2 for the local priorities, so the prevention and early intervention and reducing the harms caused by drug and alcohol. And I'm interested in what's your strategic approach with education providers in Perth and Kinross to make sure that we're making the most of the prevention and early intervention strategies that need to be in place, particularly when we see rising numbers of young people engaging with alcohol and drugs earlier. So I'm just interested to know what the strategy is for that across Perth and Kinross.
Thank you. That work will be taken forward partly through our Children, Young People and Families group when we look at schools, but also we will have a separate focus, I think, on prevention this time round, which will be a slightly different way that we did things previously. We have really good engagement from lots of education partners when it comes to work in the ADP, and what we'll be doing is developing our plans around this priority to look at some of the things that we can do. You're right, there are real concerns around issues in schools, and that prevention agenda is very important. There's some really great projects that have been going on during the duration of the last plan. For example, our drug ambassador work has proved to be very positive, and part of the work that we're going to be undertaking is to try and expand projects like that. But what we're keen to do is to try and bring everything together into a whole and into a far more strategic plan, because there's been, as I said, there's been lots of great work happening before, but it really needs to come together into that one evidence-based plan. Scottish Government a few years ago produced sort of what works as far as prevention goes, and that's obviously something that we'll be drawing on greatly when we design this new plan. But we'll very much be guided by our partners. We'll very much listen to what they have to say, what they would like to do, including our police colleagues as well, and develop a coherent strategy that hopefully will produce some really positive outcomes. Continue that work.
Thanks very much for that. I think for me it's really important that all education providers are engaged in this strategy. So schools, obviously children and families, schools, college, you've got a really good resource there to access an awful lot of people that go through Perth College UHI. So I think it's engaging all of that, because you can get to lots of people through the education provision, and I think it's important working with Police Scotland for the whole prevention and intervention agenda. You can really maximise the potential if your strategy is clear with all partners. So I look forward to seeing that. Thank you.
Thank you. And there's an importance there as well, working across Tayside as we do as well, and we're working very closely with our Tayside ADPs to look at this issue as well. Drug trends are incredibly important here, and we've mentioned previously the importance of looking at this. Drug trends are changing very, very quickly, particularly with the introduction of synthetic opioids. It's incredibly difficult to keep pace with what's happening, but it's very important that we do. It's very important that we understand what our young people are perhaps experimenting with, or perhaps being coerced into. So that will be part of our learning. But it is really important that we keep up to date and we keep evolving this plan and strategy. And that's one thing with our new strategy. Although obviously we've produced a three-year strategic delivery plan, it won't be a static document. We need to make sure that we continually update it so that we can respond to the information that we're getting in.
Mr Black, you've got another one.
Thanks. I forgot this question. Like, it's just like me, and nobody seems to ever be able to answer the question to me, and it may well be that it's not the remit of ADPs, but on a cost analysis, see the impact of somebody going through a system on hospitals, police, housing, social work. Nobody actually could say. I mean, I could go to prison now, and what I would say 70% of people in prison have got literacy problems, housing problems, and drug problems. So that's a huge impact. Before they get in prison, they're hitting hospitals, they're hitting doctors, they're hitting social workers, they're hitting police, and the cost is immense. But there seems to be no cost analysis at all on the impact of addiction. And it concerns me. And I'm not trying to separate drugs and alcohol because they're both lethal. They're both lethal, but the impact of a legitimate drug, alcohol, the impact in society far exceeds the impact of drugs. And you're taking a legal substance. But how much is that? How much is that costing society for that person not to be helped? Not to be helped. And I go to where I put my declaration, it was the financial, of course, but my declaration of interest. If you read the Cochrane review, which is the gold standard of reviews, and they're now come down on the side that 12-step recovery programs are more valuable than what we're providing, and that's been replicated. There was a recent newspaper article in the Independent that took forward. So I would point people to have a look at the impact from the Cochrane review and why they're actually saying what we've got existing now is no hacking it. It's no hacking it, as well as other alternatives.
I'll invite you in, but I don't know what the current figure is, but certainly around 15 years ago, I think there was a statistic or a calculation done that £1 invested in I think it was specifically drug rehabilitation would save the public purse £10 across the piece of health, police, justice, public sectors. But I don't know if you want to come in about the Cochrane review, or if you have a more up-to-date statistic than my 15-year-old.
I'm afraid I don't. But I mean, certainly residential rehab. The prices vary, but you know, it's an expensive service. It can be thousands of pounds a week, and you know, we certainly have seen figures in terms of working days lost just due to alcohol, and it runs into the millions. So, yeah, I mean, substance use in general costs society millions, if not billions, a year. We can speak to our colleagues in public health and see if they do have a total figure and get back to you. But yeah, the cost is considerable.
And that independent review and that recent paper article in the Independent, the reckon that alcohol costs 3.5 billion.
Okay, thanks. I see Dr. Fletcher is with us and has just put her camera on, so I don't know if you want to come in at that point on the public health aspect, please.
I think the point that Martin raises is very relevant in terms of just highlighting how important a prevention and early intervention approach is. I don't have the specific figures, but as people have described, the cost is quite significant, and there is very good evidence that demonstrates that any prevention and early intervention approach will yield a significant invest to save element. So Martin, I wonder if I can work with yourselves and ADP colleagues out with the meeting and we can get that information that you're looking for. Thank you.
Thank you. Mr. Black's nodding, Dr. Fletcher. Councillor Illingworth, you're next.
Thank you, Chair. You mentioned that drug and alcohol abuse is rising amongst young people. Now, we've got a generation sensible who don't get pregnant. They're focused on exams. They're focused on getting jobs. They get into less trouble with the police. So, is it the case that things are getting a little bit worse, or is it? And so, what's the evidence?
The data is mixed. In some senses, there are reductions as far as alcohol consumption and drug consumption goes. However, it's not a huge reduction in the sense that it's a, you know, maybe just a handful of people. So there's still a significant issue there. I wouldn't want to give the impression that things are rising out of control. That's not the case. But there is a significant still body there, and it's something that we have to look at very carefully, because obviously the harm that's done from people who are maybe using substances, experimenting with things is significant. You know, we do have some data from the Health and Wellbeing Survey, and we used to have data from SALSIS. So, you know, we do have some information there. There's also some data from the Planet Youth work that's going on in different pilot sites around Scotland. So, you know, we do have some relevant data that can guide us, but it is important that we keep that focus on early intervention and prevention because of the harms that can lead on to.
Thank you. And I think Dr. Fletcher, you wanted to come in on that as well.
Yes, just to add, we have the nationally published statistics shows that Scotland-wide and the UK-wide position is that there is significant continuing harm, both related to alcohol and substance use. For example, the alcohol-related deaths. We are still more than double the rates of the early 1990s, and we are one of the worst in Western Europe in terms of the harm incurred. The significant drivers that continue include the cost of living crisis. So there are huge pressures that continue, and health inequalities continue to increase at this current point in time. So I think we just need to be very aware of that and the impact that alcohol and drugs continues to have on our communities, despite improvements in recent years.
Okay, thank you very much. Are there any more questions or comments on the report? Either in the chamber or online? No? Okay. Thank you very much, Mr. Ogilvie, Mr. Cramner, for your presentation, but thanks more so for the work of the Alcohol and Drug Partnership. I think the reporting survey is a very positive update that we all on the board welcome. Can I invite the board to approve the strategic delivery plan for 24 to 27? Can we also approve the annual reporting survey for 23-24? And can we therefore agree to direct Perth and Kinross Council and NHS Tayside to deliver the delegated drug and alcohol services in a manner supporting the delivery of the key outcomes contained in the delivery plan? Thank you very much. Oh, Serene, you wanted to come in?
Not to do anything other than what you've said. It's just a question over the period of the report. It's likely there are going to be changes in the market and numbers of deaths, suicides or whatever. I was wanting to make sure we can give an opportunity for them to come back and update us, and if there's anything that we require to do more in terms of the report.
Thank you. I'm just going to look at my colleagues for confirmation, but I understand that we do have an annual update. But I suppose the commitment would be an annual update. But if there was any exceptional circumstances or exceptions that we'd want to bring back for your attention that required a change in that direction, we would bring it back.
Thank you very much. Time went. Would people like a 5 or 10 minute break before we go on to the next item, which, well, the next couple of items, which could be quite substantial? We have been here for an hour and a half, so if we return at 2:40, 8 minutes, or let's make it 2:45. Okay, thank you. We'll just be adjourned for nearly 15 minutes. Okay, thanks very much all. We will move on to the next item on the agenda, which is the 3-year workforce plan update. here to introduce it, we have Tracy Hunter, who's our Workforce Planning Programme Manager, and I think you've got a few slides to put up on screen. Over to you.
Oh, sorry, thanks, Chair. I'll just start off by introducing Tracy. I mean, this report provides an update on the progress of the implementation of the 3-year workforce plan for the Perth and Kinross Health and Social Care Partnership. This plan was approved by the IJB in June 2022, and in the last update we said we're in the process of recruiting our workforce planning programme manager. And as you say, we have now recruited to that post, and it was Tracy Hunter who's a successful person, and I'll now pass you over to Tracy.
Thank you, Kenny. Thank you, Chair. Good afternoon. As Kenny said, I am the Workforce Planning Programme Manager now for Perth and Kinross Partnership. Came into post at the beginning of February, and the first task that I was given was to look and review the 3-year workforce plan. So the following report and presentation is going to give that update of where we currently are sitting and the short-term and medium-term actions that we're putting forward. Next slide, please. Thank you. So the review of the 3-year workforce plan, and if you'll remember, it was quite a lengthy and complex document to start with. So as I say, first task was to look at that and to really break that down into our short and medium term action plans over the next 6 to 12 months. And to do that aligned, and it was already previously aligned to the 5 pillars of workforce planning as set by the National Workforce Strategy documentation. So the 5 workforce pillars of planning are plan, attract, train, employ and nurture. And you'll see from Appendix 1 how we have aligned our short and medium term actions under each of the 5 pillars. This work is being overseen by the Workforce Steering Group, and quickly recognised that from the actions, this is a considerable piece of work, the number of actions there, and we then subsequently developed our 4 sub-working groups to take these actions forward. So the working groups that have been developed are the Education and Development, the Safer Staffing Group, the Recruitment, Retention and Attraction Group, and the Staff Health and Wellbeing Group. And these groups are now up and running with lots of keen interest and really approaching it on that collaborative way of working across health and social care. Next slide, please. So looking at recruitment and retention, and you'll see from the report that the partnership are involved in a number and participating in a number of national programmes, including the Band 4 assistant practitioner work, involved in the Centre of Workforce Supply Group. We're also sit and are heavily involved in the healthcare staffing programme, looking at the implementation of the health and care staffing legislation that I'll discuss further on. We currently are involved very much in international recruitment, and I'm pleased to announce that we have 2 internationally recruited social care workers arriving in the country from the Philippines tomorrow, and a further 4 arriving in the country next week, which, you know, we obviously will welcome them with open arms and support them in embedding and working well in our workforce. There's been a number of recruitment campaigns using various media platforms, including Facebook, you know, billboards. You've probably seen it on various bus stops as you've been driving around the area. So a number of recruitment campaigns have taken place to varying degrees of success, but very much as we move forward in our action plan, we're plan to engage with our youngsters, our youth, our school leavers, and very much involved in the Youth Academy within Perth and Kinross and the wider NHS Tayside to look at how we can bring the youth into our workforce and offer them career development pathways. You know, we want them to come into our workforce and we want them to stay, but we appreciate that they're looking at how their careers can develop over time. So very much engaging with youth groups, and also our HEIs, our colleges, to look at the career development pathways moving forward. This year we will be welcoming 28 newly graduated practitioners, so that's our newly graduated nurses into the organisation, into adult inpatient areas, into our community teams, and also for the first time into our community mental health teams and also prisoner healthcare. So that'll be later on in the year, but again, really looking forward to bringing them in, and obviously the skills that they'll already bring into the organisation and that sharing there. Our newly qualified social workers, we're being involved and we're one of 10 test pilot areas to look at a year supported framework for our newly qualified social workers, and there's been funding secured to spread that out further. That funding's been secured and provided by SSSC, which is really encouraging, especially for us, and as I say, we were one of the first test pilots within nationally. Our AHP teams have been attended and been involved in succession planning workshops to look at succession planning and sustainability of services within AHPs, our allied health professional groups. Again, lots of great feedback there and how we're going to move that forward. And within our action plan, we are looking at succession planning, linking in with our learning and development teams within NHS Tayside, and also locally within Perth and Kinross, to look at those succession planning for our leadership and growing our own staff and what we could do to support them into new leadership roles as moving forward. You'll see from the report that we have had a decrease in our vacancy numbers within social care and also within nursing, which is encouraging considering, as you're very much aware, there is a huge workforce crisis just now, but we have had a small decrease in the number of vacancies. As the Chief Officer mentioned at the beginning of the meeting, what matters to you has been very much pivotal, I would say, and a huge, encouraging and very well received piece of work, and that will continue to also, you know, that supports our staff and health and wellbeing moving forward. Next slide, please. So thinking about how we're developing new ways of working and that sustainability of our services, and recognising that the demographics in our ageing population, we are currently embarked on a review and locality integrated teams piece of work, and that's following 6 steps workforce planning methodology that's within our older people services. We had 2 engagement sessions last week with staff. The sessions were very well attended. Feedback is very encouraging. I would say we had over 100 staff attend those sessions. Great engagement, great collaboration, a lot of suggestions and comments from staff on how we can develop our integrated services moving forward. So that piece of work is ongoing. There's a working group well set up. We have project management support there, so really encouraging, and we've got a timeline for completion of that moving forward. As I already previously mentioned, the introduction of the Band 4 assistant practitioner role. We currently have 4 assistant practitioners within allied health professional teams. That work has came by the involvement of the national piece of work for the Band 2 to 4 healthcare support worker framework, career development framework. We'll be moving that forward. working alongside NHS Tayside as we look to see how that role can be further developed within our teams. It's not been without, I would say, some hurdles, but very much the evidence is there that that role is having a huge impact in the way that service has been delivered. Our development of our advanced practice roles continues, and we're currently working on the development of a competency framework within primary care for advanced nurse practitioners. I've mentioned the supported year for our newly qualified social workers. And the last point there is that the use of our staffing level workload tools. This is a legislative requirement under the Health and Care Staff in Scotland Act, and we are aligning that the use of the tools to the PAN NHS Tayside schedule. That's not to say that we won't use the tools when required, but under legislation we have to use them annually to meet the terms of legislation to support our workforce planning development moving forward. And we're currently running 2 of the tools at the minute within Perth and Kinross services, the community tool and the mental health tool within inpatient services. Great engagement, a lot of education and training around that being provided and support, but a really worthy and huge piece of work as well. Next slide, please. I've touched on the Health and Care Staff in Scotland Act, all the work that we're doing, all the work around our workforce development, workforce plans are underpinned by the Health and Care Staff in Scotland Act 2019, which came into force from the 1st of April this year. And the purpose of the Act is to ensure that we've got obviously the right staff with the right skills in the right place at the right time to deliver that high quality of care and our services. The Act places different requirements on health and healthcare provision and care services provisions. We're working through that just now in terms of what that means for us operationally. It's nothing new. We've got processes in place, we've got governance structures in place, but there is now that requirement that we'll have to annually report into Scottish Government on how we are complying with the legislation itself. We are very much linked in with the implementation board within NHS Tayside and also the 2 other partnerships, Angus and Dundee. So we're working on that collaboratively to ensure that we're meeting the terms of requirements there of the legislation. Happy to take any questions. I appreciate that was quite a whistle stop and the report has got quite a lot of information in it.
Thank you very much. Mr. Black, you've got the first question.
Thanks very much for the report, much appreciate it. You're talking about with the young people, is there any opportunities that there could be training bursaries for young people? Is that an option that could maybe be looked at, considered? I know money's tight everywhere, but if you're working with young people, we can have an opportunity. And the second one I had, the people who are coming from the Philippines, who will be employing them, and do they do it under the sponsorship or how is that achieved?
Yeah, the people coming from the Philippines are employed by Perth and Kinross Council, and they are sponsored. Yeah. In terms of bursaries, I mean, again, that's something we could look at. Like you say, money is tight. I mean, what we do, I mean, for example, if you come in, you're employed for the council in a social care job, you're provided with all the training that you require for the social care post, plus there's opportunity for up to 4 people a year to engage in their social work training to get their social work qualification as well. And then when you become a social worker, you can get your MHO training, which is funded as well. So it's more we offer people support for training once they're in the post rather than necessarily bursaries.
Sorry, I was just to come in as well. There's the DWP are also looking at earn as you learn schemes as well for young people. You know, looking at placements into health and social care on that earn as you learn platform, which is really encouraging as well. You know, a taste of giving them, I suppose, an insight into how health and social care works, and if that's a career pathway that they'd be interested in. But again, that's through DWP, and I know HEIs are involved in looking at that as well, universities, etc.
Dr. Doyle.
Thank you, and thank you for your report. It shows there's been an awful lot of work done here. We obviously have the same issues in secondary care around about recruitment. There's a couple of things, I guess, round about your social care officer vacancies, nursing vacancies, but also the OT vacancies have increased from 0 to 10 whole-time equivalents. That obviously causes me some concern when I'm thinking about flow through the system and how we ensure that patients coming in the front door, we're getting them through the system as quick as we can. And obviously the whole multidisciplinary team is essential in that. Are you doing any work specifically around about OTs and how we try to recruit them? Because obviously that'll have a significant impact. If we have people staying in hospital longer, we've got more delayed discharges, it's difficult to get people in. You know, there's a whole load of issues around about that if we don't maintain shorter lengths of stay and trying to get people flow working through the whole system.
This one's working. Yeah, we're absolutely recognising, you know, it swings and roundabouts. For a while, we've had a real lack of podiatrists actually, and we've managed through sort of education and training and student placements to attract much more in the way of podiatrists into the system. So we're almost nearly fully staffed, but with the next round of recruitment. So the 10 whole-time equivalents is a combination across health and social care, OTs, but it's not that we're not recruiting. You know, we'll still recruit to those posts if, you know, it just happens to be the gap at the time. But we are seeing an issue in and around the sort of OT service. So we've begun a piece of work looking at the redesign of our AHP services, and we're going to start with the inpatient services around PRI in particular, and then move into the community and look at the integrated roles across OTs in the community, and again then the outpatient MSK type responsibilities, because we need to see just how we're working across the whole system and how we can improve. And our skill mix isn't great in and around the AHP services. We're quite high on, you know, our band 7s and 6s, but we don't have that band 4s. You said we were beginning to look at the band 4 roles because they can do so much in terms of capacity and flow and movement of patients as well. So yeah, we've just appointed somebody to lead that program of work for us. So we'll be starting quite soon. So you'll be hearing more about it.
I think that's really welcomed, particularly because, you know, we have through Discharge Without Delay programme from the Scottish Government, we're encouraged to have 20% of our weekly discharges discharged at the weekends. And I do know because of vacancies, we've not been able to maintain that at weekends because of that vacancy factor. So I think it is really important that we continue that and welcome that piece of work.
We have given a commitment through the whole system work that we're working with our acute colleagues on to consider weekend discharging as well. So how we can do that within the whole transformation. So hopefully we'll get there soon.
We got any more questions or comments on the report? Oh, Councillor McCall.
Thank you, Chair. I think I've got 2 points stroke questions to raise. One is really about traction in the first place and working with young people, particularly in schools. Separately to this forum, I've been in discussion with the director of people at NHS Tayside about how we engage more with schools in Perth and Kinross, and that's at very early stages, but I'm just wondering what discussions, if any, you've had with her. And the second one really is perhaps a little bit more difficult to put into a question, so I'll just stay what my mind's thinking. and again, it's to do with pathways, but it's also about retention to some extent. Somewhere along the way, I think we need to consider how we align with the wider whole system of care and support, because we have a lot of people who work in the care sector, particularly care at home and in residential care settings. I'm not sure how the professionalisation of those roles work, and whether or not there's a pathway for people in those settings and in those workplaces to be able to see a clear pathway into the types of roles that we can offer here. But equally vice versa. There may be people who feel for family circumstances or particular whatever stage they are in their careers, they may want something that's perhaps a little bit more appropriate to where they are right now. How do we make sure people can maybe not move out of the sector altogether, but move into a different pathway? So how are those pathways, or how are those roles all somehow integrated as part of one whole system workforce scenario? Thank you.
Thank you. Yes, I have been involved in conversations around and through the Youth Academy. We sit on that same forum. They're discussing how we're going to go out to our young people, what that's going to look like. How do we speak to our young people? You know, I'm getting on a bit now, but they're using different social media. There's different ways that I'm hearing these different online digital resources and platforms that we could reach out to them, not going out, I suppose, in that traditional way of this is what we do, you know, and this, they want more, they want to see how they can develop their career, what opportunities they are. And I think now, thinking of that Gen Z, it's more for them, it's that work-life balance, but for them it's more that life balance. So how can we maybe look at that differently to bring them into our organisations?
Thank you, that's really helpful. I mean, one of the things that we don't do as much in Perth and Kinross is having, you know, like recruitment roadshows almost in the schools. I know that it happens quite a lot in Dundee and I think in Angus to some extent, but from the health board's perspective. So I think joining up in that sort of initiative would be really good, so we can talk to our education colleagues, you know, on how we can maybe facilitate that a bit more. In terms of the Gen Z, we do have, I do know we have some younger social workers here, you know, who work for us who perhaps maybe aren't Gen Z, but they're maybe around about that age group. Maybe we can utilise some of those resources and skills and knowledge in age demographics a bit more as well. I know a few of the social workers who are probably children, even grandchildren of my peers, but I think we need to be a bit creative about how we do that. And that's a really good point that you made about making sure the approach is correct. Thank you. Thank you, Chair.
Serene.
Thank you. I'm going back to about 2000, or between 1998 and 2000. If I remember right, there was a national campaign then by the NHS to persuade people who had left for whatever reasons to return. And my memory is that worked quite well for a period. It's not a silver bullet, but it may well be quite worthwhile. Or do you do that as a matter of course? Do you know somebody, try and persuade them to come back?
And we have various options now for retired to return type roles, are encouraging people back into the system, so not losing the skill set that people have, and being able then to use that skill set to bring on other people as well. So there's lots of encouragement now to not lose staff, and to look at that succession planning. That's a big area as well, about succession planning for people early in the journey, so that we're not having all that skill walk out the door, because that's what happened for quite a while, and we can't afford for that to happen anymore. So yeah, lots of opportunities now.
Thanks. It's not a question. Don't worry, Tracy. I was just going to say, that this report, as been said, just sets out a huge amount of work that's been happening. But I think we need to recognise that Perth and Kinross, as a locality, if you like, as a local authority, it is very difficult at times to recruit to certain areas. So, and it is probably the most challenging area in Perth and in Tayside, so we don't compare well with Dundee and Angus in terms of recruitment, and particularly into certain roles, and particularly when we get into the north locality as well. It's very difficult, and so irrespective of all this fantastic work, it's not a job done. It's a continual process of continually going back over and finding what works and the right routes for us. But it's just to acknowledge that, Tracy. Thank you.
And I think maybe I would add just that when I was up in Pitlochry Community Hospital last week, there was a staff member who'd come up to Perth and Kinross from Camden or London anyway, but also there was a lot of flexibility around the number of shifts that were offered to nursing staff to be able to manage that work-life balance, but also maintain registration and put stuff back. So there are definite flexibilities within the system and attractions for people to come and live and work in Perth and Kinross. Have we got any more questions on the workforce plan? That online? No. Okay. Thank you very much for the presentation and for the report. I know that a healthy and engaged workforce is certainly one of the absolute foundations on which is needed for the Health and Social Care Partnership to be able to deliver the right care in the right place at the right time for the residents of Perth and Kinross. I would maybe just go back and reflect. I've mentioned it before, but I would maybe just go back and reflect again about the dedication of the staff that was demonstrated towards the end of last year when we had the severe weather events, flooding, roads closed right across Perth and Kinross, and the negligible number of, for example, care visits that were lost during that time. It's certainly, as an example, but across the whole Health and Social Care Partnership, as an example, that's a great one to show the dedication of our staff. Can I invite the board to note the progress in implementation of the 3-year workforce plan and to request an update in 12 months? Agreed. Thank you very much. Thank you very much, Tracy. I know that was your first attendance at the IJB, so thank you very much for that. Right, we'll now move on to the Integration Joint Board's strategic plan. This is an update. Currently, we have the 20 to 25 plan, but we're producing an update which from now 2024, which will take us through to 2027. I think Zoe Robertson is going to introduce the report.
Thank you. Yeah, so the purpose of this report is to seek the IGB's approval for the refreshed what is now called strategic plan as opposed to strategic commissioning plan. So by way of background, and you'll be familiar because we've presented on this before, each integration authority must produce a strategic commissioning plan that sets out how they will plan and deliver services for their area over the medium term using integrated budgets under their control. And stakeholders must be fully engaged in the preparation, publication and review of said plan. An integration authority is required to review its plan at least every 3 years and may carry out additional reviews from time to time. When they're undertaking that review, they must consider the national health and wellbeing outcomes, the indicators associated with those, integration delivery principles and the views of the strategic planning group. As Councillor Stewart's mentioned, we have an existing 2020 to 25 plan, but it was developed during 2019 prior to the pandemic, prior to the Feely review and prior to the announcement of the proposals for a national care service, and so it was deemed that a refresh was necessary. This process has taken probably something in the region of 18 months to get to this point. The first stage in that process was the undertaking of our joint strategic needs assessment. We undertook that during 22 and 23, its purpose being to provide a clear understanding of health and social care needs of our local population and is in the appendix to the report. won't be going over it. It's a rather lengthy document. There are some highlights within this report itself. The findings from the GSNA are not entirely unexpected and articulate what we know to be areas of significant demand now and as we move forwards. In terms of volume, that older people population and increasing older population is predominant, reducing workforce age group and our rurality, as we've discussed several times today, pose particular issues for us that the strategic plan seeks to tackle. That's not to diminish in any way, shape or form the specialist user groups that sit within the GSNA and the targeted interventions that are required in order for us to make improvements in those areas of delivery additionally. After we undertook our joint strategic needs assessment, we went out to consultation and involvement, and we were particularly keen that when we went out to consultation and involvement that it was informed by the joint strategic needs assessment. So when we went out into localities, we produced materials so that members of the public could look and read information about what the information was that we had gathered and make informed decision based on their experience of services, but also what that joint strategic needs information provided them with. So active involvement of the community plays a pivotal role in driving the transformation of health and social care and improving outcomes for communities, and we place a really significant importance on actively seeking that input and feedback for those who access our services in order that we are seen to co-create and shape future service delivery. So the aims of the consultation for the plan were to involve people in shaping the future of health and social care services, to develop a better understanding of what matters to people, to inform people of the challenges facing the health and social care partnership and seek their views on what did they feel, think and want, what needs to be changed or improved, how could things be done differently, and to provide a range of opportunities for people to engage with the consultation. To maximise public involvement and participation, we used a mixed approach to engagement, and by using both quantitative and qualitative methods, it provided a more comprehensive and holistic understanding of the issues, needs and experiences of individuals and communities. And to ensure that a wide range of voices was heard, a participation programme was agreed, which offered participants a range of accessible opportunities to engage in locality drop-in events via an online questionnaire or through targeted focus groups. Following the collation of the data from all localities, drop-ins, questionnaires and targeted focus group sessions, the following information was recurringly articulated and was highly pertinent to the formation of our new strategic plan. We specifically asked people to rate how important specific aspects of their health and social care was to them, and the underlying within the report are areas that people reported on being of particular importance to them. At the top of that list was that people could access health and social care support in one place close to home, that information was clearer and more accessible, that there were more opportunities to support health and well-being in their local community, to provide opportunities for local communities to influence how health and social care budgets should be spent, that people were particularly concerned that they would get out of a hospital environment as quickly as possible, that technology could be used to assist people to stay at home, that there were more consistent and regular opportunities for carers, health and well-being to be supported, that was quicker access to health and social care support through telecare and internet services, and that opportunities for volunteering, peer support as safe alternatives to services was something that a proportion of people felt was important to them. When we asked people to tell us about the challenges that they faced, people talked about access and distance to services being a significant challenge. Knowing where to go was a challenge for them. Finding the time, access to information, finance or money was a challenge for some people. Finding the support to access services was challenging. Some people said that the relationships they had with professionals was at times challenging, that their caring responsibilities impact on their ability to access services, and transport again was problematic. So people are clearly saying and consistently said through all forms of engagement that they wanted to access support in their own communities where possible and where safe to do so, and that having access to multidisciplines in one building would be preferential. People were clear that they wanted to be involved in the planning and design of how services were delivered. And of the 14% who were dissatisfied, the comments that they made in areas of in relation to challenge were that distance and access to services, waiting times and delays in support, a lack of joined up working between services, quality of care and support, and having to repeat their same story multiple times were particularly relevant. We also ran a workforce development session specifically, and the workforce produced 4 themes, and they talked about things that were important to them and what mattered to them. They talked about increased integration of services of support within the partnership would lead, in their view, to improved service delivery, ensuring that we have the right services in the right place and people know how and where to access them. We need to consider a range of approaches to improve time efficiency for social care workers, particularly those working in rural areas and moving between appointments, and that continuous feedback is important and valued by the workforce, that they're involved in planning and decision making in relation to how we deliver what we do. We followed up that consultation with strategic planning group and integrated joint board consultations. We had a joint session in September of 23, which offered the opportunity for the strategic planning group and IGB membership to consider high-level information gathered from both the joint strategic needs assessment and the consultation activity, and to gather further feedback that would inform the refreshed plan. And we took the opportunity to look at priorities identified in other strategic plans across Scotland, and what we liked and didn't like about some of those. The update paper was brought to the November 23 IGB and proposed that the data gathered through these various consultations and in combination with existing intelligence, including the Public Health Annual Report or locality profiles, would be used to produce a first draft of the strategic plan, and that we would bring this on the 20th of February 24. The strategic planning group met in March to discuss the first draft, and each priority within the plan has been considered, and a range of comments have been collated and have been applied to the plan. A first draft was presented to the IGB in a development session, and subsequently an abbreviated presentation was delivered to the Integrated Joint Board on the 20th of March, and with the agreement that a final draft would be brought to this meeting today. So the content of the plan, the vision of the plan builds on our work to support people to live good and fulfilling lives. It's set in the context of today, and it reflects what we've learned from the challenges we've faced in recent years and what we know is important to people. We want to be ambitious and we want to innovate, but we're also planning this at a time of unprecedented increase in demand and complexity of need, when public sector finances are increasingly pressured and as we face significant recruitment challenges. We know if we continue to deliver the same services in the same way, that we will face a significant financial gap over the next 3 years, and that we will risk over-promising and under-delivering. So we know that we need to be transformative in our thinking, the way we organise ourselves and in our approach to providing and arranging care and support services. So the plan opens by articulating our vision, that we want every person in Perth and Kinross to live in the place they call home, with the people and things they love, in good health and with the care and support they need, in communities that look out for one another and in doing the things that matter most to them. The plan moves on to articulate our priorities, ambitions and underpinning principles of early intervention, person-centred approaches and best value. And then the 7 priorities are articulated, which are targeting resources to where people and communities need help most, providing health and social care supports close to home, make it easy for people to understand where and how to access services, work with communities to design health and social care supports that they need, promoting self-management and well-being, improved integrated working, and to value our workforce, support them to keep well, learn and developed. Our ambitions are that we want people to stay as well as possible for as long as possible. We want people to live as independently as possible for as safely as possible. And we want people to be able to thrive and feel valued members of their community. Each priority identified resonates with what both our communities and our staff told us during the consultation process. The intention of the plan is to be clear that we are listening to the people who live and work in Perth and Kinross and who come into contact with health and social care services. The priorities are applicable to us all, no matter what type of service we're accessing, and each has linked strategies, delivery plans or transformation programmes that describe specific actions and timeframes that will enable them to improve their services over the next 3 years. Each of the 7 priorities are codependent on one another. For the whole system to function effectively, we'll be focused not only ensuring each independent priority is progressed, but that they all move forward in synergy with one another. The plan describes how it's supported by our linked transformational projects, whose objectives are to transform services to meet current and future demands, and how this will involve service design, collaboration with other services and third parties, investment in some areas with disinvestment in others, and innovation in recruitment and retention. The plan discusses performance measurement, our statutory obligations, including our duty to measure the progress we make against the 9 health and wellbeing outcomes, but also references public health strategy and our commitment to ensuring we play a part in the successful delivery of these priorities. We further go on to discuss local arrangements and our intention to publish a performance framework in 2024. With regards to finances, the 24-25 budget and 25-26-27 provisional budget was approved by the IGB in March 24, recognising the significant gap within the provisional budgets for 25-26 and 26-27. The budget review group will continue to meet throughout 24-25, and it will consider additional funding solutions and reductions in expenditure required, and how this can be achieved with minimal impact on the strategic plan and to the population's health and care needs. The proposed 24-25 budget has been developed and considered with IGB members via budget review group meetings held in January, February, and at a budget development session on the 12th of December and 23rd of February 24. So in conclusion, our strategic plan aims to map a realistic picture of a complicated landscape. It creates the conditions to share resources, maximise the potential of the totality of our assets, and strive ahead with our vision, ambitions and priorities. We ask that the plan is approved by the IGB and agree that the directions in relation to the strategic plan are delivered via the mechanism of user delivery plans and/or strategies. And updates on the implementation of the plan will be provided via our annual performance report and updates on those said plans, strategies and projects.
Thank you. Thank you very much for the report. I know that there was a huge amount of work went into, not least of all the engagement required for the joint strategic needs assessment, and then this plan builds on top of that assessment. Have we got any questions or comments from the board? Councillor McCall.
Thank you. Thank you, Zoe, for this. It's a pretty comprehensive piece of work, so thank you very much. I think where one of my commentary probably is around the care at home provision as opposed to the residential care provision, because particularly in the rural localities, where very often the providers that support people living in the city don't necessarily go very far out of there, not even to the smaller settlements like Bridgeverne or wherever, they're just effectively almost joined up to the city. So I'd be interested in knowing how we can address some of that. And I think the other thing is, I was looking at the housing statement and the increase in demand in the under 64 age demographic, and particularly people with not just learning disabilities, but people with other support needs. Their needs of where they live may change and migrate, and I know currently it's extremely difficult for those needs to be given enough priority, and that can then affect their mental health and their well-being and the support that they need, etc., etc. And that's just perhaps to do with aging or to do with their changing as people grow up. To some extent, their needs and demands change. So the provision of care providers across the whole of Perth and Kinross is a concern. And the other part then is, how do we make sure that as people's needs change, that they can be addressed and captured in the other services that are provided? Thank you.
It feels quite a fortuitous question to ask in relation to care at home. I have to say, we have the care at home contracts live at the moment, and we had over 60 notes of interest in the end in the contract, which is a phenomenal level of interest, I have to say, and not something I've experienced since I've been in this role. And we've now narrowed that down to 28 providers who have bid on multiple areas, and particularly the north locality, which we have never experienced either. So, and I'm not sure what I put that down to particularly. I'd like to say it was our lovely, lovely tender, but there's a change, I think, in terms of health and social care provision coming out of the COVID pandemic, and an element of recovery in there. Whether or not they're all successful in that area or not is another thing, but certainly I feel much more hopeful about that rural provision of care at home. But we're also working with 2 of the trusts within Kinlochrannoch and Burnham and Dunkeld around alternative models of care at home delivery. Burnham and Dunkeld have already established a model and have been working with us to improve referrals into that model. And Kinlochrannoch have undertaken, and I think I spoke about this in a previous meeting, their consultation and sort of micro needs assessment for the area, and have identified a group of 15 people in the area who would be keen to deliver a care at home type provision. So we're working with them to look at what that model could look like, and to work with them to make sure that it's one that's right for that area and right for those individual people. I would say the one thing that we know is that whatever works in one area won't necessarily work in another. So we're working on it in that kind of bespoke, designed way with the communities. And I have to say those 2 trusts in particular have led those developments with support from the Health and Social Care Partnership, as opposed to the other way around. And I think that's why they're working. Regards the increase in demand under 64, there might be other people that might want to come in this one, but one of the things that I would talk about is the work that we're doing with Hillcrest in Aberfeldy, and the learning disability core and cluster development that's being built there for people who live in Aberfeldy who have a learning disability and want to stay in their own communities. And I think we need to do more work like that, working with communities to enable people to stay in the community in which they want to live, and to ensure that when we do build core and clusters, that they are suitable for people at all of their stages of life, and that they don't get to a certain stage and it no longer works for them, for example. So really thinking about that long-term accessibility of the housing.
Thanks. I know it's been a continual issue about making sure that we've got provision spread right across the area, so that's a really encouraging development. Dr. Doyle.
Thanks. It's a great strategy, and looking at the strategy on our page, I think Jackie had shared it with us at one of the development events. I was just reflecting on it, thinking about the CMO's realistic medicine paper, but also his discussion around about recovery, redesign and reform, and really having to change our services. And you talking about these repeat stories. We often see that when people come into hospital, that they have to retell their history multiple times, and there's nothing more frustrating for them. And a lot of what we've done is around about streamlining that service. But I was trying to think about it in a community perspective, and thinking about getting rid of duplication and waste in an environment where, you know, we're under so much financial scrutiny at the moment. But that's also one of the realistic medicine principles, isn't it? Reducing duplication and waste, and thinking about innovation and improvement. I just wondered what the digital infrastructure was around about that, to try and improve or enable communications to improve between primary, secondary care, but also between other providers, and how that could help to reduce some of that duplication and waste, and for the individual person at the centre of it to stop having to tell the story multiple times.
I'm not going to be able to answer that one, funnily enough, but there's one thing I would add, and that I have, and I haven't been able to engage in this much more than I have at the moment, but there's a realistic medicines app that's been produced at the moment as well, which enables people to bring with them a sort of overview, I suppose, of their concerns and worries in relation to appointments, and can be shared with practitioners. And I would be keen to explore that in further depth of detail. But what it didn't do is it didn't share it in advance with, for example, if you were going to see your consultant. And I'm saying it was feels like a major flaw in that for me, in terms of people having to then come in and share the story via the app, as opposed to the person seeing it in advance. But I'm sure there'll be other people who've got a more wise answer to that question. But thank you.
There's two things I was just going to say in response, Monica. The first one was that the council is very shortly replacing its social work, social care database with a system called Mosaic. Now, I'm assured by the suppliers of that and the people who are in charge of that it is more likely to be able to integrate with health systems than others. So we're probably in a good place with that. So that's the digital bit. But the other question was around, I suppose, efficiency. And in here, and I can't find it in the document. You'll need to tell me what page it is. But you'll see that there's the 5 transformation projects, and some of that is very much about reducing duplication, reducing inefficiency, and that's really important in such a large geographical area. So some of that will be related to technology, so enabling people to record things without returning back to base, but also not travelling backwards and forwards or crossing over each other. So we recognise we've got a lot to do in that, but it's on our radar and we're working on it.
And I think you wanted to come in this point, Dr. Peterson.
Yeah, as part of the ITA, I always think that we also need to think about the national perspective. So I know that, and you'll know about this, about things like the Respect project, which was initially started, although it's about future care planning, the actual basis of it was to look at a framework that would then be able to be shared with patients, with care homes, with carers, with social work. So there's also something about us being involved in those projects, but also keeping an eye on what's happening nationally, because the Respect digital project started as a way to hopefully enhance and see what we could find. And as we know now, Respect can also, the framework they've done, can even swap health boards. The first one done was actually done in Forth Valley and ended up in NHS Tayside. So we need to be aware of that as well, the national position.
Thank you, Mrs. Auld.
Thank you. Zoe, thank you very much for that update. It's really reassuring to hear of the bespoke nature of the work. I heard a presentation recently from Derek Feely, who described his desire really for a move away from the use of person-centred, because he was finding that what was happening was that the healthcare professionals were working independently from the person, and actually was suggesting, should we be moving more towards a collaborative approach and collaborative thinking, and that seemed to make some sense. My comment about, I was really struck when I read the document on the high percentage, 60% of people who responded said that they had an issue with access and distance, that was a challenge, and I just felt that really brings it home on everything that we're doing around providing services, where where a prime focus should be around the rurality issues that we've touched on a number of times already are so pertinent to so many people. So it was just a comment on that. Thank you.
Okay, thanks very much. The point is very well made. Mr. Black, I think you're next.
Just on that access, and I believe that access sometimes is limited with the ability for literacy. So I think a lot of access needs to be pictorial. We need to or change the way that provide that information. And off the wall one for me, I think everybody should have their own information on a band, so somebody just scans it. And everybody, you do that with some dogs. You put a chip in them or a cat. You just put a band in a human being with all their information, so people can come along and scan it. Save a lot of money.
The health literacy certainly is spoken about in the second last priority, and the detrimental impact that can have for people, and is a focus for us certainly moving forwards. And we also talk about that in the equalities section about how we communicate what the services are that we have, and that has to be accessible to everybody. And it's why the plan's been written the way it's been written as well, to make it as accessible as we can make it, to use everyday language, and that it's not a report for us sitting here necessarily, it's a report for members of the public to be able to pick up and access and be able to understand what it actually means.
Councillor McCall again.
Just as a follow-up to that, I mean, I have one or two in this room might have heard me saying before, I think we should produce a lot of these documents in easy read format, and we don't do it as a matter of course, not just in the Health and Social Care Partnership, or the IGB rather, but in the council as a whole, or the health board for that matter. So I think if we maybe start thinking how we can achieve that in due course, I think it'd be really helpful.
We will produce this in an easy read format. That's in our plan, and we've actually recruited to one of our graduate apprentices, and one of his tasks alongside updating our website is to undertake the easy read training, so that he can be a resource specifically for us, because we tap into somebody who does that on the side of what they normally do, because we do see it as a priority.
Yeah, I think that's true. Just from personal experience, that not just easy read, but also using different types of communication tools is hugely important. Not just for us in the IGB or in the Health and Social Care Partnership, but also for our care at home providers. And the training isn't often available to them, or the resources are not available to them. So therefore, communication to and from vulnerable people in particular is sometimes lacking, as we can describe it. So I think that's a really good development. So I'm really pleased to hear it. Thank you.
Thank you. And I just wanted to ask about the need for the way that the priorities in the strategic plan are going to be delivered is through the individual delivery plans and strategies and so on, and what the schedule will be for bringing forward updates to those delivery plans and strategies.
Yeah, so we've deliberately pitched the plan at a high enough level and then underpinned it with the delivery plans. So there's a schedule of delivery plans coming through the integrated joint board, which have either fully developed performance frameworks sitting underneath them, or performance frameworks in the development process. And that will be the mechanism by which we measure our achievement of the intention of the strategic plan, but additionally through our annual performance report as another measure, and through audit and performance committee in terms of performance measurements.
Thank you. Have we got any more questions or comments in the room or online? Nope. Okay. Thank you very much then for the report. A great piece of work to produce this new strategic plan. Can I invite the board to approve the final version of the Perth and Kinross IJB Strategic Plan 24 to 27 and agree that directions in relation to the plan are delivered via the mechanism of delivery plans? Agreed? Thank you very much. Next item on the agenda then is the an update from the strategic planning group and a draft alongside the draft minute of 30th of April of this year. Is it Serene or Zoe? Serene.
It will probably be a joint approach round the table then to go from last time. Thanks so much, Chair. The minute is actually quite useful because it gives you a flavour of the discussions we had. The ACP one in particular, what happened today mirrored the group in terms of questioning the reasons behind the plan and the objectives of the plan and the improvements in the plan. And it led me to think about over the summer when we're not meeting, how we can do a better job in terms of this group. Because it's no point in just mirroring and passing on to you to approve in the minutes. We should be doing some of the heavy working with you as a committee, because you don't want to get into it. It's just a bore in the sense of a report comes, a bit discussion, and it comes straight here for the same thing. And so I think it is important to think about that over the summer, Chair, and come back to you with either ideas to improve things or apologies from me for wasting your time. So the area strategy update was indeed again a very interesting discussion and debate, and we were looking at how we could improve access in terms of the work that's already been done about young carers and about the role of young carers in terms of developing ideas and providing facilities that they'd want to manage and support. And so I made contact following the meeting with a very young, active chairman of a council in the northeast of England who did a lot of work for the young carers. And they did in fact contact us back and were keen to me to provide details of showing others to come and talk with them about what they can do and help in terms of the role that they play with young people. They're a national body and they'd be delighted to talk about how best to champion the role of young carers. So I'll be doing that for the next meeting. The other issue around this was that we didn't have a great deal of discussion on the strategic plan, because if my memory is correct, we were just about to complete it. And so it was a flavour was given in terms of the debate today. But again, it was something that the members really welcomed in terms of its quality and the depth it goes into in terms of all aspects of the strategy. And so that was welcome. The workforce plan, if I could afford to employ Banner, I would do. I mean, she's really on the ball in terms of the efforts being made in terms of the workforce. It must be one of the most difficult jobs in the public sector, because planning is actually more than that, in the sense that having planned what you want to do is persuading people to do it, persuading people to stay and do it, or persuade people to come in to do it, and with all the other pressures. And so again, it was a very positive discussion about the workforce planning update. And in that discussion, some people raised the issue about how do we improve young people's understanding and view of health and social care. Some of us felt it perhaps in all the criticism, legitimate or otherwise, but that young people were getting the wrong impression about having a career in health and social care. It was a skivvy job, poorly paid, and no career prospects. And we thought there was something we could look at in how we improve that in respect of the work that's being done and whether we can up the ante in terms of getting a greater group of young people to consider it seriously as about I can see it as a career, and linking that with the nursing training, and to look at whether or not during nursing training and training in social care side to at some point in the development for the nursing side and the caring side to do some joint training and joint working, so as the next generation comes into the workforce, they've already got an idea and an aspect of how to work together. And I think that was important. So, and the last thing was the transport strategy. Now that was really a really good debate, because transport is something we've raised here in terms of rural services and the ability for people to access rural services and the use of public transport. And the three staff members who came, lead officer for local transport and two of his colleagues, and one of them has some expertise in housing. And the debate was centred around how best the transport strategy could be improved. Two areas. One is loss of access between Ninewells and facilities in the Perth area which are used via Ninewells, and that the transport company had withdrawn that service, and it has been withdrawn. There's already cases of people being unable either to get to work or to get to Dundee to receive their advice and their training. We also thought that transport was very important to our wellbeing strategy. Loneliness and unable to access on a regular basis family, friends, other opportunities, and we thought it was important that the strategy reflected that as well. But again, it was a very much a worthwhile debate around the strategy, and so I thank the colleagues, and I hope this is going to be, if it does, I apologise, but I hope this in the future a better interaction at these meetings with other parts of the services, and because at the end of that meeting we had transport, housing and ourselves all agreeing there's a requirement to really focus between us to get the gains that's necessary. So that's the report. I'm happy to answer any questions.
Thank you very much. Have we got any questions about the business of the strategic planning group from anybody? Or comments? No. Oh, go on then. Thought you were going to get off there, Serene. Councillor McCall.
No, it's really just an administration thing at the bottom of the report that says the date of the next meeting is before the date of the minutes of that meeting. So I was just a bit confused. So it just shows, just to let you know, I do read the papers.
Okay, if there's no other questions on the strategic planning group update, we'll move on to the last thing on our agenda today, which is the work plan update for both the board meetings and for the development session work, the future development sessions. Have we got any questions on those items? No. Is that, are those future work plans acceptable to everybody? Okay, thank you very much. Just before we close, I am going to say thank you very much to Evelyn Devine, our Head of Health, who is with us for the last time in your role as Head of Health for the Social Health and Social Care Partnership at the IJB meeting. And we've got some flowers from you, from the Chief Officer. Evelyn has had a very Evelyn's had a very long career with the Health and Social Care Partnership, and prior to that, I think the CHP. So thank you very much for the for your service to the health of residents in Perth and Kinross. Thank you. Members, thank you very much for your attendance and for your engagement this afternoon, and the meeting is now closed. Thank you.